Thank you very much, Mark, for the introduction. I'm very happy to be here, and I'll be talking about predictive modeling with electronic medical records compared to insurance claims data. And as Mark was saying, this is mostly joint work with Clalit and with with a team of interdisciplinary team of academics from Israel, from Stanford, and from this institution that is, I think, uniquely positioned to address some of these interesting questions because, as Mark said, it covers more than half of the Israeli population. It has adopted long ago EHR, and it owns and operates a third of Israeli general hospitals. And we acknowledge funding from the Center for Population Health in Stanford. So basically, as we hear a lot these couple of days, big data and predictive modeling are transforming healthcare. And the basic paradigm in which these things are happening around us is that data from multiple sources is being used with machine learning and modeling techniques to generate useful predictions. And those predictions are useful because they allow us to change actions in the healthcare system. For example, you can target diagnostic testings that are expensive to patients that are most likely that's going to matter for them to find out the result, not for patients with very low probability for the outcome in the first place. You can improve diagnostic accuracy, and you can improve the precision of medicine. Namely, you can treat rather than the average patient, you can match better the treatments to patients. And we economists are often the ones who spoil the party by reminding everyone that there are resource constraints. And so we are particularly excited about these new opportunities to match patients with the right treatments, because they could both reduce the cost and improve the quality of care. So for one example, I was more personally involved with in Israel, the reduction of hospital readmission rates. So around the same time, Medicare was introducing its hospital readmission reduction program. Israel had its own, and Clalit, the biggest organization, was responding by taking all the information available in the history of patients' records and modeling readmission risk, and using this model to continuously flag patients. The timing was that you got the score already at the day of admission, so you can flag patients for special attention by providers, both within the hospital, during the admission, and not less importantly, after discharge in the community. And analyzing this data, we show that basically this has led within 2 years to a 6% reduction in 30-day readmission rates, actually also over longer horizons, and an even larger reduction among the target high-risk population. And this is particularly exciting because it's a scalable intervention. This was done at a very large scale. But the problem is that often the biggest challenge isn't the modeling. These advances in machine learning are moving very fast. It's actually access to data. You might not have the data you want to generate those granular predictions. And so we set to explore this, and in particular, this contrast between electronic medical records on the one hand and insurance claims on the other. And Clalit is particularly suited to study that because uniquely they have both data for the entire population. And so let me tell you a little bit more about the comparison between those data types. I'm sure many of you are familiar. So insurance claims are those data that have been around for decades and we've been using for research and policy for a long time. These data are collected for billing purposes. They're highly standardized. There are forms to submit claims, and therefore they're very similar across institutions, but they contain relatively fewer variables. So they have diagnosis codes and dates, and pretty much it, and payments. But the big advantage of these data is that they're broadly available. In my research, I used the entire Medicare population data for a decade, and you can easily get access for research for nearly the universe of employer-sponsored Americans. So basically, you have data on the entire population. In contrast, electronic medical records have been fascinating us recently because they are collected not just for billing, but for treating. So they have an immense variety of additional variables. You can see blood tests, you can see vital signs, and you can have multiple measurements over a period of time, which you can compare. And that is leading us to think that there could be many great things we can predict with those data that we can actually not predict just with claims data. But the problem with EMR is that they are very messy to work with. They are much less structured, many systems generate them, and they are much more sensitive and therefore siloed, not just across the organizations, but often even within the organization. And virtually we just don't have them for the entire US population. At best we have them for some system, but this is of course changing. At this point in time we don't have them for the entire population. So we set to ask the basic question of what are the gains in predictive performance for actually augmenting this well familiar and more available claims data with this additional tier of electronic medical records. So our design was fairly simple. We took a sample for just 1 year of all hospitalizations in Israel with a history of all patient records from before that, and compared two types of data. We collected both types of data, but we split it to using just claims data on the one hand, and using both claims augmented with EMR data on the other hand. And we used off-the-shelf machine learning methods to predict. So that's lasso, ElasticNet, Forest, and we use the usual techniques to make sure we don't overfit the data because we have thousands of variables, so we need to select and regularize. And we use these models to predict 4 common and important outcomes. Admission length, whether or not it's above, it would be more than 1 week. The timing is the day of admission. 30-day readmission rate after this index admission, inpatient mortality, and mortality within 1 year of the index admission. So here are the results. You can see here for the 4 outcomes, from left to right, it's the length of stay, readmission, and mortality inside the hospital and after. You can see the accuracy measure, and this is the area under the receiver operating curve. If you don't know it, basically this is 0.5 is just guessing and 1 is knowing for certain. And this is, just to be clear, performance measures on new data that was not used to train the model. So this is fresh testing data on which we estimate predictive performance. And you can see first that it's not as easy to predict different outcomes. So it's easier to predict mortality than it is to predict 30-day readmission, for example. But our main interest was not comparing outcomes, but rather comparing data sets. So here is what we found when we included the EMR data in addition to the claims. So there is an improvement, and you can bootstrap and see it's statistically significant, but you really have to squint to see the magnitude of this improvement. So basically, the predictive performance of EMR data, when you augment them to rich claims data that include the diagnosis codes, are relatively small. And that made us worry. We did all the target leak checks and the bunch of stuff that you should be doing. But we also said, okay, let's compare this to a crude predictor that doesn't include diagnosis codes and rather just takes from claim demographic information and total cost in 20 categories. So how much you spend in 2 years on hospitalizations, on imaging, and so forth. And you can see that when you do that, you actually perform worse. So it's not to say that these outcomes are easy to predict anyway, or with any data, but rather that you really need the diagnosis codes, but then in some sense, when you have them, they're sufficient. And perhaps it's not surprising because we have tens of thousands of codes, and experts, doctors, look at your blood tests and code these codes, so maybe they contain the right amount of information. So to conclude, we found for these specific outcomes in our context that EMR hardly improved predictive performance. This is not to say, I want to stress, that EMR are not useful or important in other contexts, or even in this context, perhaps for other outcomes or other horizons. Good luck trying to predict septic shocks in the ICU using claims data. You really need granular data. But for many applications, I think the takeaway is that standard, widely available insurance claims that we're already been working with and are much more widely available may be sufficient. And I think these are very good news for research and policy, because it means that we could push forward faster in using data to improve healthcare. Thank you very much.